Hello everyone and welcome to another video of our Internal Medicine Board Review question series. This series relates to nephrology for the most part. This is part 9 and the focus is on renal replacement therapy or dialysis. I'm Dr. Mohammed Tinawi. I'm a nephrologist in Northwest Indiana. You can find more about my background in the description below. Some of the information in this series and in this video is based on my book, Manual Fluid, Electrolyte, and Acid-Base Disorders. You can find more in the link below. My book now is in its second edition. So we'll go ahead and get started. Question number 1. A 58-year-old man with stage 5 chronic kidney disease due to diabetic nephropathy presents for a regular renal clinic visit. He has no nausea, vomiting, itching, insomnia, or anorexia. He has mild fatigue. BUN is 66 mg per deciliter and creatinine is 6.3 mg per deciliter. Potassium 5.1 milliequivalents per liter. Estimated GFR is 9. What is the next step in the management of this patient? A. Initiate hemodialysis now via a subclavian non-tunneled catheter. B. Initiate hemodialysis now via a right internal jugular tunneled catheter. C. Insert a peritoneal dialysis catheter and start peritoneal dialysis after 4 weeks. D. Refer for kidney transplantation evaluation. So as per our previous videos, you can pause the video here, think about these different options, and once you choose an answer, you can advance to the next video. Next slide, the answer will be on the next slide. So the answer is D, refer for kidney transplantation evaluation. So this patient does not have uremic symptoms except for maybe mild fatigue. Therefore, immediate initiation of dialysis, whether hemodialysis or peritoneal, is not indicated. Now, option A is not a good option. We never put a subclavian catheter because this leads to subclavian stenosis. Then you cannot put a catheter or a fistula in that arm. So that's a bad choice. B is not necessary. There's no indication for immediate dialysis, whether hemo or peritoneal, so that also takes care of C. So D is kidney transplantation. So once estimated GFR is below 20, you can refer for kidney transplantation evaluation. So that is the preferred option. Another good option would have been creation of arteriovenous fistula if the patient wants to pursue hemodialysis, also because the GFR is below 20, but I did not provide that option. Okay, moving on to question number 2. A 78-year-old man with end-stage renal disease due to diabetic nephropathy presents to the emergency department with fever, chills, malaise, and hypotension. Now, this patient is on hemodialysis via a right internal jugular tunneled catheter. On examination, he is lethargic, blood pressure is 88/57, heart rate 135 beats per minute, and temperature is 39 Celsius. Labs, BUN is 66, creatinine is 6.1, both in milligram per deciliter, potassium 5 milliequivalents per liter, white count is 20,000 with 78% neutrophils and 8% bands. What is the next step in the management of this patient? A. Start intravenous antibiotics immediately. Exchange the tunneled catheter over a guide wire, so you put another tunneled catheter. B. Start intravenous antibiotics immediately. Remove the tunneled catheter. Start hemodialysis after a day or 2 via a non-tunneled dialysis catheter. C. Start intravenous antibiotics, remove the tunneled catheter only if the condition worsens. So you wait a day or 2. If the patient worsens, then you remove the catheter. D. Remove the tunneled catheter and proceed with acute start peritoneal dialysis. So think about these different options, and the answer will be on the next slide. So you can pause here if you like. The answer is B. Start intravenous antibiotics immediately, remove the tunneled catheter, and start hemodialysis after a day or two via a non-tunneled catheter. Now, this patient is septic, obviously. You have fever, you have hypotension, you have tachycardia, leukocytosis, left shift bandemia. So you don't need more than that. Moreover, he's lethargic. So this patient is sepsis. So you give antibiotics immediately in the emergency room before anything else. Okay, so now we started the patient on intravenous antibiotics such as piperacillin tazobactam plus vancomycin, for example. So we started those, and then we immediately removed the tunneled catheter. Okay, we give the patient a line holiday, maybe for a day or two, longer if you can, and then you insert a non-tunneled catheter and you start dialysis. Once repeat blood cultures are negative, then you can insert a new tunneled hemodialysis catheter, and this patient really needs a permanent access AV fistula, AV graft, or a switch to peritoneal dialysis. So that's answer B. Answer A is incorrect because you don't want to remove a tunneled catheter and place another tunneled catheter because that new one can also get infected. The patient is still septic, so it's not a good option. Option C, to wait, well, you can't wait, okay? The patient is septic, and if you wait, there is a chance of a very high mortality. Option D, there's no need to proceed with acute start peritoneal dialysis. Moreover, option D does not have starting intravenous antibiotics. So even if you're in a center where they do acute start PD, which is not a bad option, option D would still be wrong because you don't have start IV antibiotics immediately. So it is incorrect. Okay, moving on to question number 3. A 48-year-old man with end-stage renal disease or end-stage kidney disease due to diabetic nephropathy. He has been on hemodialysis via an arteriovenous fistula, AV fistula, for 3 months. The patient has no nausea, no vomiting, itching, insomnia, or anorexia. Monthly labs show a KT over V. Okay, this is the dialysis clearance measurement. We measure once a month in every hemodialysis patient. Is 1.7, which is good. We aim for 1.2 to 1.4, so he is getting good dialysis. BUN 46, creatinine 5.3, both in milligram per deciliter. Potassium is elevated at 6.1 milliequivalents per liter. His potassium was 5.8 last month. Now, the patient is not on any medication that is associated with hyperkalemia. So he is not on, say, lisinopril or losartan. He's not on potassium supplements. He's not on salt substitutes, etc. Dietary counseling regarding low potassium diet was provided. What is the next step in the management? What is the best answer? A, increase dialysis time from 4.5 hours, which is the current time, to 6 hours to remove more potassium, of course. B, change potassium bath from 2.0, the current bath, to 0 for the duration of dialysis, meaning for 4.5 hours. So this way we can remove more potassium with dialysis by lowering the potassium bath. C, change dialysis modality to peritoneal dialysis. So put a dialysis catheter, and then once it's ready, you discontinue hemodialysis and you pursue peritoneal dialysis. Or is it D, start a potassium binder? So think about these different options, and the correct answer will be on the next slide. The correct answer is D, start a potassium binder. Option A would probably solve the problem, but patients are not going to sit for 6 hours. Plus that will be inconvenient for the dialysis facility to have someone staying for like 1.5 shift. So I've been doing this for a long time. I don't think any patient I know would stay for 6 hours. Option B, changing dialysis bath to 0, also would achieve normal potassium level, but it is dangerous. That's associated with arrhythmias, so it's really a poor choice. Changing to peritoneal dialysis, option C, is also incorrect because hemodialysis is even better in removing potassium than peritoneal dialysis. And here you're also complicating the issue. You may need large volume peritoneal dialysis. So option D is the best answer. And here we are looking for the best answer. So starting a potassium binder, especially one of those new binders, the sodium zirconium cyclosilicate, also known as Lokelma, or Piturimer, known as Veltassa, both are approved for long-term use in dialysis patients. Now, this picture shows you the different chemical structure of sodium polystyrene sulfonate. On the left, this is the old K-exylate, and then in the middle, the sodium zirconium cyclosilicate, or Lokelma, and to the far right, the Piturimer, or Veltassa. So each one is very different from the other chemically. And I'm not going to spend time on this table. This is available in my book, the chapter on potassium binder. You can pause the video here and read about the differences between these different binders. Again, for someone on chronic renal replacement therapy, we're going to choose Piturimer or sodium zirconium cyclosilicate, usually not sodium polystyrene sulfonate. And you don't have to use it every day. It can be 3 times a week, can be on non-dialysis day, twice a week, depending on the situation. Okay, now we move to question number 4. Now, question number 4, here we have a 48-year-old man with end-stage renal disease due to diabetic nephropathy. He presents with excessive interdialytic weight gain. So his weight gain between dialysis treatment is high. He's been on hemodialysis via an arteriovenous fistula for 5 years. He's anuric. He doesn't make any urine. Last hemodialysis was 2 days ago. On exam, blood pressure is elevated, 178 over 77 millimeters mercury. Target weight or dry weight is 70 kilogram. His pre-hemodialysis weight, so he came to dialysis at 77 kilogram, and he left at 70 kilogram at his target weight. So his gain is what? 7 kilograms. On exam, he had 1+ pitting edema in the lower extremities, lamps, BUN 65, creatinine 6.2, both in milligram per deciliter, potassium 5.1 ml equivalent per liter. His sodium pre-dialysis was 130, and it was measured immediately post-dialysis, and it was 138. What is his estimated interdialytic sodium intake over the past 2 days? So now we want to calculate how much sodium he's taking in between treatment to determine if he's compliant with a low sodium diet. Is he compliant with fluids? Recommended intake is about 100 ml equivalent per day. So is it 175 ml equivalents? Option A, or option B, which is 200, option C, 225, or is it option D, 250 ml equivalents per day? I mean, not per day, actually per 2 days at the interdialytic period. So here you really have to pause the slide because you have to make calculations. The correct answer is 175 ml equivalents over 2 days. And that is option A. So how did we arrive to this number? Now, that's not that difficult. His pre-hemodialysis total body sodium is pre-hemodialysis weight divided by 2. This is now the volume, the total body water, times pre-hemodialysis sodium. So he weighs 77 kilogram divided by 2. This is his volume, okay, total body water. Okay, times 130, which is the sodium pre-dialysis, and we get this number, 5,005 ml equivalents. This is pre-dialysis. Okay, now post-dialysis, he left at 70 kilogram, divided by 2 is the total body water or volume, so this is 35, times the sodium post-dialysis, which is 138. So we get here 4,830 ml equivalents, okay, post-dialysis. So how much sodium did he take in over the past 2 days is the difference, okay? And this is actually how much sodium we removed with dialysis. So we get 175 milliequivalents. So this is less than 100 milliequivalent per day. This is equivalent to about 4 grams per 2 days or 2 grams per day. So his compliance, his adherence to low sodium diet is good. So what's the problem here? He's drinking too much water, okay? So his sodium intake is fine. It's about 100 milliequivalent per day. But he is drinking too much liquids, about 3.5 per day. So that's too much. So we need to counsel him on fluid restriction. And you kind of deduce that just looking at the serum sodium 130, and someone is not making urine, and uric is what? Dilutional. So he's diluting his sodium by his water intake. Let's move on to question number 5. A 58-year-old man with end-stage renal disease secondary to IgA nephropathy presents with fatigue. This patient has been on hemodialysis via AV fistula for 1 month. He has no nausea, vomiting, itching, insomnia, or anorexia. Pre-hemodialysis blood pressure is 151/74. Monthly labs. KT over V is 1.6. So again, he's getting adequate dialysis, adequate clearance. Minimum is 1.2 to 1.4. So 1.6 is good. BUN is 45, creatinine 5.2 milligram per deciliter. These numbers are pre-dialysis, okay? The monthly labs are drawn monthly before the patient goes on dialysis. Potassium 4.9 milliequivalents per liter. Hemoglobin is low, 8.8 gram per deciliter. He's 58 years old. He underwent GI evaluation. He had EGD, colonoscopy. There was nothing. The patient is started on erythropoietin, okay, Epogen, and intravenous iron because his ferritin was low, was 98, and his iron saturation was 17%. So he was started on intravenous iron. He was started on iron sucrose, 100 milligram with every dialysis treatment for 10 treatments, and then 50 milligram per week. And he was started on Epogen, erythropoietin alpha. What is an acceptable hemoglobin target? Is it A, 7 to 9 gram per deciliter? Is it B, 10 to 12 gram per deciliter? Is it C, 12 to 14 gram per deciliter? Or is it D, Epogen is contraindicated because his blood pressure is uncontrolled, and Epogen will raise his blood pressure further. So the correct answer will be on the next slide, and the right answer is B, 10 to 12 gram per deciliter. So option A is too low. Option B is based on clinical studies, and this is what the current recommendations from the international societies, KDIGO. C is too high, 12 to 14, maybe associated with harm. And EPO, yes, it can raise blood pressure, but blood pressure 151/74 is not that high. And you can do other things, maybe increase ultrafiltration or give more medications to control blood pressure. So it's not a contraindication to starting Epogen. There has been many trials to determine the best course of action with regard to Epogen. The most important of these trials are these three: the CREATE trial, the CHOIR trial, and the ACCORD trial. You can easily Google these names and you'll get the full results of the trials. But this recommendation of 10 to 12 gram per deciliter hemoglobin for dialysis patient is based on the combined results of all these trials. And what these trials try to achieve is whether a higher hemoglobin would prevent left ventricular hypertrophy, whether it would reduce cardiovascular morbidity and mortality, does it delay progression of chronic kidney disease, that's in non-dialysis patient, what's the effect on stroke and heart failure and hospitalization. Basically, you target hemoglobin 10 to 12, okay, and that will prevent blood transfusion, and that's about it, okay? A higher hemoglobin will not reduce mortality, will not reduce stroke. If anything, it can increase it, especially in diabetic, and definitely will not reduce cardiovascular mortality. So we are much more conservative now with the Epogen than we used to be years and years ago. So 10 to 12 is a reasonable target in hemodialysis patients. Same for peritoneal dialysis patients. Okay, Let's move on to question number 6. A 58-year-old man on peritoneal dialysis for end-stage kidney disease secondary to diabetic nephropathy. He presents with abdominal pain, nausea, and vomiting for 5 days. On exam, he has a temperature of 38.6 Celsius, blood pressure 93 over 49 millimeter of mercury. His abdomen is diffusely tender. His PD catheter exercise shows no erythema or drainage. PD effluent white cell count is 2,000, and for us, anything above 100 is abnormal, especially if you need to have like more than 50% neutrophils. So this patient has 70% neutrophils. Okay, so subsequently, the patient was started on vancomycin and cefepime intraperitoneally, IP. Symptoms and white count in the peritoneal effluent did not improve after 4 days, and now we have the culture result. It is growing Candida albicans. So we have fungal peritonitis. What is the next step in the management of this peritoneal dialysis patient with fungal peritonitis? A, perform peritoneal lavage by surgery. B, give amphotericin B intravenously. C, remove his PD catheter and start fluconazole intravenously. D, start fluconazole intravenously and remove PD catheter if there's no improvement after 4 more days. So you can think about these different options, and the correct answer is C, remove PD catheter and start intravenous fluconazole. So basically, fungal peritonitis, the catheter has to come out, okay? Has to come out sooner rather than later. Otherwise, the patient may die. Okay, so yes, you have to give antifungal treatment, but he cannot wait. So if you get Candida after 1 day, 2 days, doesn't matter. The catheter will come out. Okay, same applies if there's no improvement after, say, 4 days of antibiotics, even if you don't know what's causing it. So the catheter will have to come out. Peritoneal lavage, yeah, that's nice. You can do it in addition to catheter removal when they're removing the catheter. Amphotericin B intravenously also would work for Candida, but is not enough. Option D, intravenous fluconazole, and then remove the catheter after 4 days. Well, the patient may not be around then, okay, so that's too late. So the answer is C. Remove the catheter immediately, and this is immediately. So you call the surgeon, they have to remove it that same day. And you start antifungal, you can start fluconazole, you can start amphotericin B, you can consult IED, you can go to UpToDate, you can give nystatin orally if you want in addition. Doesn't matter, the catheter will have to come out. Okay, now moving on to question number 7. So probably the nephrologists in the audience will like this question. A 48-year-old man on peritoneal dialysis for end-stage renal disease secondary to membranous nephropathy. His peritoneal dialysis prescription weekly KT over V urea is 1.6. How is total KT over V is calculated to meet an adequacy goal of 2? So what am I talking about here? We have a patient on peritoneal dialysis. We want to make sure that we are providing adequate peritoneal dialysis. So when we do that, we have to calculate KT over V for urea. K means clearance, T means time, V is the volume, which is approximately body weight divided by 2. So we calculate this urea clearance, okay, for 1 week from his peritoneal dialysis, okay, and we want to achieve a target of 2.0, okay. So how do we do that? How do we calculate the total KT over V? A, we do a 24-hour urine collection for urea, okay, and then we add the urine KT over V urea to peritoneal KT over V. So this means that the total KT over V is the peritoneal KT over V plus the urine urea KT over V. B, we're done. We just calculate the peritoneal because residual renal function has no role. Okay. C, 24-hour urine collection for creatinine. Now we add the urine KT over V creatinine to the peritoneal KT over V urea, or is it D, we have to do a nuclear medicine scan to determine the residual glomerular filtration rate accurately, and then we add that to peritoneal KT over V. So you can think about these different options, and the correct answer will be on the next slide. Now, of course, the nephrologists in the audience know the answer, and they do calculate total KT over V by adding the peritoneal KT over V to the urine KT over V urea. Okay, and this is how you get total KT over V, and it should be at least 1.7, preferably 2. Residual renal function has a role, okay, has a big role. So option B is incorrect. C, the calculation for creatinine is nice if you want to calculate creatinine clearance weekly, and we do that, and we would like it maybe to be over 50, the KT over V applies to urea, not creatinine. And D, nuclear med scan is very laborious, very expensive. There's no way to do that every 3 months for every patient. So option D is not the best option. Okay, now for those who are interested and intrigued in calculating KT over V urea and KT over V in the urine, this is how we do it. If you're not interested, just move on to question number 8, but I'm going to mention the steps here. Okay, so let's take this example. 60 kilogram woman on continuous ambulatory peritoneal dialysis. Her drain volume is 9, so we collected everything she drained over 24 hours, all the bags, okay, 4 bags in that case, and we weigh them, okay, and we got 9 kilograms, so this is approximately 9 liters. Okay, next step, we measured the urea in that liquid, in the dialysate, and it was 40 milligram per deciliter. Then we measured the blood urea nitrogen, and it was 42. Okay, so first step, we calculate D over P, dialysate over we calculate dialysate over plasma urea, okay? So the dialysate is 40, plasma is 42, so we get 0.95, okay? This has no unit because it's milligram per deciliter or milligram per deciliter, so they cancel out. So D over P urea, dialysate over plasma urea is 0.95, okay? Now the clearance, the KT, the clearance times is 0.9, okay? This is the D over P times 9, what we got volume for 1 day. It's 8.55 liters. So this is the daily peritoneal urea clearance. And we achieve that again. We divide the urea in the dialysate by the urea in the plasma, and we multiply that by the drain volume. So this is how we got the 8.55. The volume, this is total body water, is 60 times 0.5, so about half, okay, approximately, so we get 30 liters. Okay, now the daily peritoneal KT over V urea, so the KT is 8.55 and the V is 30, so we divide 8.55 by 30, we get 0.285. And again, this has no unit because it's liter over liter, they cancel out. And weekly, if the daily is 0.285, weekly we multiply by 7 and we get 2. Okay, so the weekly peritoneal KT over V urea is 2. Now we have to calculate the residual urea, okay, the residual renal function urea. So how do we do that, okay? Now, again, we have the 60 kilogram woman on CAPD, drain volume 9, the dialysate urea 40, BUN 42, and here we do a 24-hour urine collection, and we get a urine urea of 210 milligram per deciliter and a urine volume of 600 ml. Okay, so now we want to calculate the urea from the 24-hour urine collection for of the urine. Okay, so KT, this is the clearance in 1 day. We get the urine urea times volume divided by plasma. So you're all familiar with the UV over P, and then usually here we say times 1440. This is how many minutes per day, but now I don't want to do it in per minute. I want to do it per day because we are doing the daily urine urea clearance. So the 210 we get it from here, times V is 600 divided by 42. This is the blood urea nitrogen. And we get a daily urine urea clearance of 3,000 ml or 3 liters. Okay. Now, this 3 liters, we divide that by 30, okay, the V. So now we got the KT. The V is the volume, and this is 60 divided by 2 is 30, so we get 0.1. Weekly, we multiply by 7, so we get 0.7. Now, total KT over V urea, meaning from peritoneal and residual urea infection, is 2 plus 0.7, and you get 2.7. Now, mercifully, there are calculators and apps that will do that for you. So you just plug in the numbers, the drain volume, the dialysate urea, the blood urea nitrogen, urine urea, urine volume, and it will spit out that number. But it'd be nice just like for one time to know how we're doing this, okay? Now, moving on to question number 8. 48-year-old woman on hemodialysis for end-stage renal disease secondary to diabetic nephropathy. Her cardiologist would like to start her on a beta blocker for heart failure with reduced ejection fraction, so for chronic systolic heart failure. He prefers an agent that is poorly dialyzable or non-dialyzable. Which beta blocker are you going to recommend for this patient? Is it A, metoprolol, B, carvedilol, C, atenolol, or D, propranolol? So think about these different options, and the correct answer is on the next slide. The correct answer is carvedilol. Why is that? Now, of all these options for heart failure with reduced ejection fraction, you can use metoprolol or carvedilol. Atenolol is highly dialyzable, and it's not indicated for that, so it's wrong for 2 reasons. Propranolol, option D, is not correct, although propranolol is poorly dialyzable, but it hasn't been studied in heart failure, so that's not a good answer. Metoprolol is good for heart failure with reduced ejection fraction, but it is highly dialyzable, so you cannot use it. So you're left with carvedilol. So for patients with heart failure with reduced ejection fraction, you can choose carvedilol or bisoprolol. Bisoprolol, I didn't mention that. It's not one of these options, but it would have been a good answer. Metoprolol is highly dialyzable, so you cannot use it. And the other answers like atenolol and propranolol, they won't matter because they're not indicated for heart failure with reduced ejection fraction. So the answer then is B, carvedilol. Moving on to question number 9. A 28-year-old woman with bipolar disorder presents with nausea, vomiting, diarrhea, delirium, and tremors. Lithium level is very elevated, 3.6 millimolar per liter. What is the preferred dialysis modality for this patient? A, acute start peritoneal dialysis. B, continuous renal replacement therapy. C, emergency hemodialysis via a non-tunneled catheter. Or is it D, gastric lavage, activated charcoal, and intravenous fluids? Then proceed with hemodialysis if there's no improvement in 3 hours. Think about these different options. The correct answer is on the next slide. The correct answer is C, emergency hemodialysis via a non-tunneled catheter. This patient is very toxic, so this lithium level is extremely high. It's above 3.5. She has clear symptoms, tremors, delirium, nausea, vomiting. So emergency hemodialysis is indicated and is life-saving, and you have to do it quickly via non-tunneled catheter. Option A is incorrect. Peritoneal dialysis would be very slow, very ineffective to remove lithium. We need something to happen now. Same for B. Continuous renal replacement therapy takes hours, so many logistics to get the solutions ready, and we need a fast dialysis, not a continuous and slow dialysis. Option D is a horrible option. You don't have time. You're not going to wait more hours. Gastric lavage, activated charcoal, IV fluids, all good. Do all that if you want, but you still have to do dialysis. Dialysis is life-saving in this patient. Okay, now moving on to the last question. A 48-year-old woman on hemodialysis via an arteriovenous fistula for focal segmental glomerulosclerosis. She presents with a serum phosphorus of 7 mg per deciliter. Dietary counseling regarding low phosphate diet was provided. What is the best next step in her management? A, you give a binder, calcium carbonate, 2,000 milligrams, like Tums, okay, 2,000 milligrams, 4 of them, 3 times daily with meals, with food. Sevelamer or Renvela, Renagel, 800 milligram 3 times daily with meals. Tenapanor, Zyvoza, 30 milligram twice daily. Or do you give sucroferric oxyhydroxide or Velphoro, 500 milligram 3 times daily with meals? So think about these different binder options. Tenapanor is not a binder really. And the correct answer is D. Why is that? Option A, calcium carbonate. Calcium carbonate is not a very effective binder, and giving 2,000 milligrams 3 times a day is not a good idea. You're giving a very high calcium load. The vessels are going to calcify if you do this for a while. So yes, you will achieve probably phosphorus control with this very big dose of calcium carbonate, but you are using 6 grams a day. That's not recommended. Okay. Sevelamer 800 milligrams 3 times a day is not going to lower a phosphorus of 7 enough to target. Target is 3.5 to 5.5, and we would like it more in the normal range, maybe close to 4. So at least you have to use 3 tablets, so 2.4 grams 3 times a day with meals. 800 milligrams is too low of a dose. Tenapanor is an add-on therapy. It's indicated by the FDA to add on to a binder. Okay, so you cannot use it by itself. It will block phosphorus absorption. So you can add that on, but you cannot use it by itself, so it's not a correct option. Now, sucroferric oxyhydroxide is a strong binder, and starting 500 milligrams 3 times daily with meals is the best option. This is Velphoro, and the dose can be increased if needed. I hope that you liked the questions here. Please like the video, subscribe to the channel, support this effort by purchasing the book on Amazon. See you in the next video.